How's it going, guys? Past level question, upper GI, steps 1 and 2. We got a 64-year-old man, 3 episodes regurgitating undigested food after meals for the past 3 months. Sometimes has a vague sensation of food sticking in his throat, gurgling and swallowing, rhonchi, heard over the right lower lobe. Just continuous low-pitched sounds can sometimes reflect aspiration, secretions. BMI 35, and then what's most likely seen, we have a very buzzy barium swallow showing Zenker diverticulum. And this is the classic vignette here. Okay, just overweight dude, middle-aged or elderly, and they can have this sensation of food sticking in their throat, gurgling when swallowing. Okay, and what's most likely to be seen, cricopharyngeal muscle spasm, correct answer. So a very buzzy answer choice will show up just like this on NBME exam. They also want you to know increased oropharyngeal pressure. That's another answer choice, okay, for Zenker diverticulum. And they want diverticulectomy on 2CK as the treatment. It sounds obvious, but shows up, okay? So very easy, very past level stuff. Let me just tell you some other high yield points real quick. Choice B, fibrosed atrophy, esophageal smooth muscle, wrong fucking answer. Refers to Crest syndrome, okay? Limited systemic sclerosis, aka limited scleroderma. So Crest, calcinosis, Raynaud phenomena, esophageal dysmotility, sclerodactyly, telangiectasias. But what they want on the NBME exam is a down arrow for both LES tone and for esophageal peristalsis in Crest syndrome. They'll give you up, down, no change, all the different combinations for those two, and it's a down arrow for both. Anti-centromere antibodies, okay, for limited type for Crest syndrome. Then, of course, if you have renal involvement causing a surge of RAS with malignant hypertension, that's anti-topoisomerase SCL70. Wrong fucking answer. Choice C, loss of neurons, myenteric plexus, wrong fucking answer. Refers to achalasia. This is increased LES tone as a result of loss of NO secreting neurons in the Auerbach plexus. And you will also do a barium. However, it will show you a bird's beak appearance. You then go on to do esophageal manometry, a pressure study for achalasia. It's almost always idiopathic, but NBME can assess Chagas disease, Trypanosoma cruzi, as a cause of achalasia. Classic presentation is going to be inability to swallow solids and liquids at the same time. Okay, if USMLE wants esophageal cancer, they'll tell you one of two things. They'll say either dysphagia of solids in a patient who has history of heavy smoking alcohol for squamous cell of the esophagus, or GERD for adenocarcinoma of the esophagus. That's the first presentation. The second is difficulty swallowing solids that progresses. The word progresses is very high yield to dysphagia of solids plus liquids. Whereas if it's neurogenic due to achalasia, it's dysphagia to solids and liquids at the same time from the start. Wrong fucking answer. Choice D, metaplasia of distal esophagus, wrong fucking answer. Obviously refers to Barrett esophagus. I mean, there's no presentation as far as pain in the throat with swallowing, okay, the classic GERD presentation, but we do have rhonchi, which sometimes you get atypical presentations for GERD, where you have aspiration pneumonia. Okay, they'll just tell you patient has nocturnal cough, recurrent aspiration pneumonia, nothing about pain, okay, or burning in the throat, and that's still going to be GERD, okay? And so when we talk about Barrett esophagus, you just have to know metaplasia is reversible, and you have conversion of non-keratinized stratified squamous of the distal esophagus goes to columnar epithelium with goblet cells, which is also known as intestinal columnar. Wrong fucking answer. Choice C, spasm esophageal muscles, wrong fucking answer. So you're wondering what's going on between this and choice A. Well, choice C refers to diffuse esophageal spasm, which can present similarly to angina and unrelated to food consumption. Okay, it can occur sporadically. And cricopharyngeus muscle associated with Zenker is not technically an esophageal muscle, OMG, okay? It's part of the upper esophageal sphincter, but spasm esophageal muscle, as I said, diffuse esophageal spasm. Choice C, wrong fucking answer. You know the deal with team, make more content, like, subscribe, appreciate your time. That's it.